Without further ado, I'll give a brief introduction to Drs. Farhat and Sue, and also want to acknowledge Mr. Farhat O'Kelly, who's joining us today from Dublin, Ireland, where he's a pediatric urologist and consultant at the Beacon Hospital. He's going to be joining the residents a little bit later this morning, a little bit later this afternoon and evening for him with our residents in the Resident Education Conference. So briefly, Dr. Farhat joined us a few years ago from the Hospital for Sick Children in Toronto. He completed his urology residency training at the American University in Beirut, followed by his fellowship at the Sick Kids in Toronto, and is the chief of our pediatric urology division. Dr. Sue is an assistant professor here in our department and completed her training in urology at University of Pittsburgh, followed by her fellowship in Seattle at the Children's Hospital. And they're going to be presenting to us this morning, as you can see, on the urologic aspects of pediatric kidney transplantation. Walid and Ruthie, the floor is yours.
Hi, good morning, everyone. Thank you, Dan, for the introductions. I think today is a medley of pediatric urologists presenting. I have Farhat as a friend. I will be officially and formally introducing him at the REC later on. But if there is one thing that I would say about Farhat is that if you look at his publications, the diversity of his publications in pediatric urology and even in adult urology previously had been outstanding. His friendship had been very helpful for us here building the division on a research level. Unfortunately, he could not make it in person to be in the US now. He has an abstract with the UW Pediatric Urology Division, and at the fall meeting, which is today, later on, we're flying out to Miami. But Dr. Bhatia agreed to present on his behalf. So thank you, Farhat, for being an associate member of the division and for providing your insight on how we can do research better. The one thing that I want to just bring up, which is really important for us, is knowing that Farhat had been recently selected as a member of the European Society of Pediatric Urology Guidelines Committee, which is really timely for us because we are soon going to start transitional urology, and Farhat and I are working hard on establishing this transitional urology clinic here at UW, taking advantage of the European history of it previously. I have few disclosures, but none of those relationships with the private companies have any impact on my presentation, or I will not be presenting anything related to those relationships. We are going to really talk about kidney transplantation in children, specifically knowing that this is the theme of the month now. And I felt like Dr. Sue and I would be a good fit to talk about what we have done since we started working closely with the Division of Pediatric Nephrology, who I extended an invitation for them to be on this grand round, and with the transplant team. I will be briefly talking about pre-transplant evaluation from a surgical perspective. I will talk about the native kidneys and the fate of the native kidneys in pediatric population. Then I will share some of my knowledge on kidney transplantation at the time when I used to be involved in them primarily in Toronto, and talk about the surgical nuances of this, and finish by talking about the bladder and ureter. And then Dr. Sue will come on board and she will discuss Vestigostomy reflux in transplant kidney and her collaboration with Europe now in progress. So I argue that in any solid organ transplantation, you have really two things that you want to be safe at. Providing adequate vascular supply and adequate immunosuppression. But I would argue that in pediatric urology, kidney transplant depends on a healthy bladder and a healthy ureter. And that's something that's not very much acknowledged in any other solid organ transplantation. And this is why I think the role of pediatric urology in kidney transplantation is really important. There are a few things that differentiate pediatric patients who need kidney transplantation than adults. And I think this is important for the residents to remember. Pediatric patients have more history of congenital anomalies, or as they call them, congenital anomalies of the kidney and the urinary tract. They have renal dysplasia, obstructive uropathy as posterior valve. You have reflux nephropathy, or patients who are born with small kidneys. and that constitutes about 30 to 35% of patients. On the other hand, adults usually do have history of diabetic nephropathy or hypertension. And the good thing about pediatric kidney transplantation is the fact that really the success for both graft and survival of the patient had been so impressive over the last maybe 20 to 25 years. And credit to be given to the army of pediatric nephrologists who really have a microscopic view of every kidney transplant done in North American continent, to the extent that, you know, if you really want to focus or look up what is new in pediatric kidney transplantation, you look up NAPROTEC. NAPROTEC stands for North American Pediatric Renal Trials and Collaborative Studies. They usually not only document, but also influence practice pattern. For instance, they will update people, including myself, and people who are interested in kidney transplant on clinical outcome of kidney transplantation, the changing trends. For instance, what they have found in 2019, and that was the last NAPROTEC publication, is that now we're doing more and more kidney transplants preemptively, meaning that the kids are not going through a dialysis cycle. What is even more important is that now we're realizing that kidney donors who are less than 5 years of age do have good outcome as kidney donors above 5 years of age. And obviously these are cadaveric kidney donors. And that's important because with the pool of kidney transplant being so little, I think it's important for us to know how we can get better at what we do and what we can offer for the young kids who need kidney transplantation. And again, credit to be given to the pediatric nephrology team who really do actually watch those patients in a longitudinal manner and give us a lot of insight on what we need to do next. Now, from a pre-transplant evaluation, I think it's important for us to just talk about the two types of pre-transplant evaluation. The nephrologist will be very aggressive in knowing the primary disease and whether there is a risk of recurrence. They want to know if there is any risk of infection, malignant risks, or importantly, if sometimes they would involve psychology, especially if you have a patient who is in pubertal, who most probably will end up having a rejection, not because of any immune response, but rather because of the patients not being very adherent to their or compliant with their treatment. So this is why, if there is any hot topic in the field of pediatric kidney transplant, is the fact on how you can transition those patients to adult clinic and make sure that they will not lose their kidney once they go through a kidney transplant early in life. Interestingly, we know that if a kidney transplant to be done, you have to really function on anatomy and function of the urinary tract. And why is that important is because the key is that we want to avoid urinary tract infection in pediatric population, because UTI, graft dysfunction, and rejection are quite common. And it's unfortunate, but it's a fact that post-transplant UTI is quite common in pediatric population. That's really because of multiple reasons. One of them is immunosuppression. The other reason is possibly because of indwelling catheters. And the third reason, most of the time, is because of pre-existing genitourinary abnormalities. And again, I want to remind the residents that it's about 30 to 35% of those patients who have kidney transplant have abnormal urinary tract. So we can get around it by giving patients antibiotics. Sometimes we stop the antibiotics after a certain period of time. But the reason to why we care too much about UTI is really because we want to make sure that we can differentiate between rejection and acute pyelonephritis, which is sometimes quite difficult. And you need to rely on a biopsy to be able to do this. And you can only imagine with the morbidity of doing biopsies on a regular basis for a patient who could be having just simple UTI is quite daunting. So this is why pediatric urology is really intertwined, as I call it, with pediatric nephrology and transplant. And pre-op urological evaluation is really crucial. This is a paper that we're going to be discussing next week, if I'm not wrong, in the Journal Club with the transplant theme, talking about the fact that if you really have urological or non-urological pathology, the outcome would be good if you're managing those patients appropriately. And we will talk about this throughout my next maybe many slides in the next 20 minutes. This is a busy algorithm. I'm going to summarize it in the next slide, but the key is that if you have a history of recurrent urinary tract infection or congenital uropathy or voiding complaints and voiding dysfunction or a bladder that had been defunctionalized, you have to really evaluate those patients more aggressively than others. You can sometimes just exclude checking on those patients beyond an ultrasound, but some patients will need much more aggressive urological evaluation. In here, you can see the summary of that algorithm. So if you have a child who have no history of upper tract abnormality or UTI, an ultrasound will be more than sufficient. If you have a child who unfortunately had history of UTI, then a VCUG will be needed to rule out reflux. If you have a patient who has spinal dystrophism or neurogenic bladder or obstructive uropathy or a cloacal anomaly, then you may need to really consider doing urodynamics. And this is the school I came from. We used to consider that every patient who has an abnormal lower urinary tract has to be recognized and corrected before kidney transplantation. In addition to the evaluation, I think it's worth a while to just talk about the nuances of pediatric kidney transplantation. Pediatric kidney transplantation is weight and height dependent. If you have a child who's less than 15 kilograms, you can for sure talk about a higher risk of complication. Could be thrombosis of the vessels, or it could be other complications such as inability to even close the abdomen because the kidney is much bigger than what you could even accommodate. Now, mind you, I came from a school where we did all our kidney transplantation through a retroperitoneal approach. And if a patient is between 15 and 30 kilograms, we used to actually be aggressive to give them a lot of heparin because we wanted to avoid thrombosis. The height is important too. If you have a kidney, as you can see in this picture, that's really bigger than the incision itself when you put it in, you have to really keep a room, find a room for that kidney. And this is why a lot of people, including the pediatric transplant surgeons here at UW, find it more comfortable to put a kidney in the abdomen itself. And there's nothing wrong with doing that. But again, from a urology perspective, I will talk about why we find that to be a limitation. When I was getting ready to move to UW, I was actually very much interested in looking at how many cases do you really need to do before you become competent at doing kidney transplantation, and what's the volume of cases you need to do. And from that paper we published in the Journal of Urology, it became clear that there are certain things that are unique for pediatric kidney transplantation, and some of them are intuitive, some of them are really related to the approach. And what I mean by this is that if you have long blood vessels in a retroperitoneal space, the blood vessels will kink. That's why you don't want to do that. On the other hand, if you're doing transperitoneal, you don't care about the length of the vessels, whether it's an artery or a vein. If you have a cadaveric kidney transplant, it would be good to have a corral patch, as we call it, or aortic and caval cuffs. Many years ago, we came up with a technique where we do the transplantation while cooling the kidney at all times. We actually sandwich it with packs of ice on both sides, and that had allowed us to avoid really counting the anxiety-provoking time of how long it's taking us to do a kidney transplantation. And that's why the warm ischemia time became less and less of an issue. Perioperative anticoagulation is important, and the reason why, again, is because when you have a kidney that's basically big and you're putting it in a patient who is very low, has very low weight, you may need to really heparinize them fully as if you're doing a cardiac procedure on them sometimes, and that has a risk of bleeding. What we found in that paper is that we really need about 17 to 20 kidney transplantation within the first few years of your practice to be able to continue doing them on a regular basis. Now, going back to the retroperitoneal or transperitoneal, it's a provocative subject because, again, I think the peritoneum is a place where we would like to keep virgin most of the time, and the reason because we would possibly need the peritoneal cavity to do major reconstructive procedures. And this is a paper we published showing that if you end up putting a kidney in the retroperitoneum, you have to really aim to get high as far as possible in the aortic bifurcation or vena caval bifurcation, because small vessels may induce delayed kidney function. It will not affect the graft survival on the long run, but it's important to be aware and cognizant about those things. And I'm looking forward really to work collaboratively with the transplant team, because there is a lot of room for research and work in this area and in knowing what happens to the kidney when transplanted in the retroperitoneum or transperitoneum. So as I said, pediatric urology is really closely intertwined with transplant team and nephrology. I mean, this is a slide that Curtis Sheldon from Cincinnati, who retired, is a pediatric urologist who was involved primarily with the kidney transplant in Cincinnati. We had the chance to talk on multiple occasions and about how we do think is different a bit about how possibly a transplant surgeon think. And we both are right. I'm not saying that any one of us is more right than the other, but we have certain things that are in our mind ahead of time. For instance, we know about the native kidney fate. We talk about how we want to remove them. We talk about stomas and incision. And this is really the key topic I would like to just highlight as why we do need to be involved in those patients primarily. Right upper quadrant is saved for the PD catheter. Left upper quadrant is saved for the G tube. Midline incisions is saved for bladder augmentation. Hockey stick incision is saved for the kidney transplant. Stomas are in the midline. And you really need to be kind of working on that landscape ahead of time. Once you see the patient first time in the clinic, we even, I mean, literally, I start imagining where everything will be falling apart when we take care of those patients. For the residents who have worked with us, you might remember that when we have a patient being prepped for a kidney transplant, we will talk about where the stoma would go midline, how the incision will be done later on by the transplant surgeon. But again, for us, or at least pediatric urology, we like to keep the peritoneal cavity really untouched. Now, talking about the fate of the native kidneys, we get involved primarily in those patients, especially when you know that the nephrologist is actually not many more interested in keeping the kidneys. And this is because the kidneys do have a role, obviously, in terms of easier fluid management, production of erythropoietin, and maintenance of vitamin D metabolism. But sometimes the kidney become an issue and we get into removing them. This is a list of indications on when to remove a kidney. I'm really going to just go through it very fast between the congenital nephrotic syndrome, polyuria, urinary tract infection. You need to be, from a surgical perspective, aware of two conditions that you may need to take the kidneys out. One is that if you have really a big kidneys that will not allow you to have a space for your transplant. This is when you have polycystic kidney disease. Another board question, which is common, is high risk of renal malignancy with Dennis-Drash syndrome. These are patients who are born with renal failure and hypospadias. Sometimes we take one kidney on the side, and the key is when do we take them and how do we take them? So for our practice and for urologists, we're very familiar with retroperitoneal space. This is here, you're looking at two positions that we use the laparoscopy to remove kidneys. Yesterday, Ali and I did the retroperitoneal laparoscopic nephrectomy on a kid who doesn't need transplant, luckily for him, but we had to put the patient in a prone position and we were away from the peritoneal cavity. You can put the patient in a flank position and you can take the kidneys out. And sometimes you take the kidneys out ahead of the transplant and sometimes you take them at the time of the transplant. But the key, again, if I want to keep on saying that forever, is to keep the peritoneal cavity really undisturbed. We want, or minimally disturbed. Here you're looking at the transperitoneal approach when a patient needed a G-tube and a nephrectomy, for instance. We take advantage of the laparoscopic approach to put a G-tube for that patient. I'm not aware of the pediatric nephrologist here doing medical nephrectomy, but maybe it's a way of really killing the kidney by giving a lot of non-steroidal anti-inflammatories. But in urology world, in pediatric urology, when you're taking a kidney out, you have to really think about the ureter and see if you can keep it. The ureter is of a paramount importance for us later on in life in those patients. This is here an example of a patient who needed a kidney transplant in the retroperitoneal space. We had to really remove the native kidney just because we were unable to put a large living-related kidney in the retroperitoneal space, and this is an indication of a nephrectomy. We're moving down to the bladder, which I think is the reason to why I believe pediatric urology is very much involved, should be involved in pediatric transplant, is the fact, again, that dysfunctional lower urinary tract will be causing urinary tract infection. Again, the percentages are there for the congenital anomalies of kidney and urinary tract or CACUT. And third of those patients, by the way, are known to have bladder dysfunction. And as I said before, if you appropriately manage those patients, you will not in any way have a risk of kidney graft failure. And this is why you have to be on board with the team when you discuss a kidney transplant ahead of time, so you plan on how you want to mitigate any of those possible complications. This is a neurogenic bladder that a patient will possibly need a kidney transplant. Those patients will possibly benefit from having the ureter be reimplanted into the kidney, into the bladder itself, if you can. Now, a lot of the time you actually do the transplant and then you realize that the patient will need an augment. That's completely acceptable. But if you end up putting a kidney into a patient who has already an augment, you have to add another list of requirements you need to be checking on the patient later on. One of them is a high risk of urinary tract infection, because those patients are on CIC or clean intermittent catheterization, and metabolic acidosis could be another risk for that. This is why pediatric nephrology would be taking care of all of that, but we as urologists need to be aware of all of those things. A common question from transplant surgeons, we have one patient now who's listed for cadaveric kidney transplant, is what is the tiny bladder going to do when you put a kidney? My impression is that the kidney will grow. And with the anticholinergics that we have and the Botox again and again, you can make the bladder actually get bigger. And if you need, there's no harm in doing an augment later on after the transplant. And I have seen a lot of bladders that actually get bigger with kidney transplantation later on. Now, filling the bladder is as important as emptying. And that's, again, another thing that we are aware of in the patients who have defunctionalized bladder. So we know that patients who have history of urinary tract infection and posterior valve or obstructive uropathy will need, at one point in their lifetime, a method to empty their bladder. And this is why Mitrofanov is a procedure of choice. This is here a patient who had his kidney transplant into a vesicostomy that we have presented few of them to date. And we ended up needing to go back into the abdomen to identify the appendix, bring it down, and do a appendicovesicostomy through a lab-assisted approach here. And the two people standing in the back there are the residents assisting us to actually do a Mitrofanov on a patient that we are basically rehabilitating the bladder again after a long time of being in a vesicostomy state. Moving down to the ureter now, I think it's another provocative subject that a lot of people talk about, whether how do you want to reimplant the ureter and the bladder and how you can avoid having reflux. The most common technique that we have used for the longest time is to just extravesically, we make a tunnel, we just put the ureter in, and we make sure that we basically keep a stent in. There are certain requirements or certain guidelines on how long the ureter you want it to be. For instance, I always tell people, when you're doing a mega ureter repair or when you're doing a kidney transplant, stretch that ureter down to the pubic bone, and this is where the maximum length of the ureter need to be there. Sometimes when you have a cadaveric kidney, unfortunately, the ureter could be so short. Sometimes it could be devascularized, and this is why, again, a ureter is another factor that may add to the complication of a kidney transplant. Now, there are patients who have their ureter reimplanted into a vesicostomy. Again, I came from a school where we did not do this. We prepared the patients ahead of time. But if you think that you're going to do that, you have to keep in mind that this might be the permanent option. Otherwise, you have to reverse the vesicostomy, and that's not an easy matter actually to take care of. We are struggling with our patients now that we have to close their vesicostomy and retrain their bladder. Ureter reimplantation, again, is tailored to the individual, and I have to really specifically explain what I mean by this. If you have a decent bladder, you do modified Lisch-Gregoire. It's extravesical reimplant, and then you will be on your way to just be having less risk. If you have an augmented or a thick bladder, unfortunately, you are going to have a risky ureter reimplantation. And this is why the native ureter is so important for the practice of pediatric kidney transplantation. Many years ago, we published a paper showing that if you have a problem with the bladder, ureter reimplantation into a hostile bladder, the native ureter will be of paramount importance again to allow you to do a uretrostomy. And even if you have more complex situation, which unfortunate sometimes, if you get a kidney that end up having a complete devascularization of the pelvis or the ureter, you end up needing to use that native ureter to replace it. This is a paper that Emmy published with us when she was rotating on the pediatric rotation. And this was on the utility of native ureter in the management of ureteral complication. Here you're looking at a pelvis that had been completely necrotic. And this is not our case here, by the way. It's from previous experience where we needed to put the ureter, native ureter into the pelvis. And a segue to Dr. Sue to present her data. I think if you want to just focus on one area of intersection between urology and transplant is the vesico-ureter reflux occurrence. And VUR could be completely of no clinical significance as long as the patient is not having recurrent urinary tract infection. But if you have a patient who has recurrent urinary tract infection, a common question in the board is whether you use deflux to repair it, and when do you really need to be more aggressive to repair it. The key is that you have to remember any patient who has recurrent urinary tract infection with a transplanted kidney to the residents, think about bladder bowel dysfunction. And that's why it had been shown that if you have patient with kidney transplant, the majority of the time you can manage their reflux by getting them to do the same urotherapy we do for bladder bowel dysfunction. But if you have a problem that's beyond reflux and UTI, you have to figure out if you want to reimplant the ureter again, and you want to really redo the whole thing down at the level of the bladder, which is not an easy task. So because reflux is a provocative subject, I think it would be worthwhile for having Ruthie talk about VUR in kidney transplantation. And obviously, after she finishes, I would love to take questions. Thank you. Ruthie, you want to share your slides?
It says that you need to stop sharing. So before I talk about reflux in the pediatric kidney transplant situation, I thought it would be useful to review what we know about reflux in the normal situation, in the non-transplant situation. And in the past 30, 40 years, the literature on reflux, it's really involved, you can't talk about reflux without talking about UTI, bladder dysfunction, and renal scarring. And we've talked about this before. What we can say for sure is that, you know, reflux, like Walid said, reflux in the presence of a UTI is what we worry about. And that sterile reflux is generally considered to be benign. And that the role of the bladder is very important. The bladder dysfunction can modify the risk of scarring in reflux. So the thing is that a lot of times when we think about reflux in the transplant situation, we infer a lot from this body of work. And the truth is that I don't know if that's the best thing, because these populations are actually quite different. As Walid said, that, you know, the transplant population is enriched with kids with K-cut, congenital anomalies of the kidney and urinary of the kidney and urinary tract. And this includes kids with posterior urethral valves, prune, and these are kids getting transplant into an abnormal urinary tract to begin with. The transplant kidney is also a solitary kidney situation with competing causes for graft dysfunction. So this is a kidney that's susceptible to infections, bacterial infections, immunosuppression, and rejection. So it's not really, so basically these ideas, the relationship between these concepts have not really been investigated very much in the transplant population. And so that is sort of what we're going to talk about today. This is an early report that sort of sounded the alarm of the role of reflux in causing late renal graft failure. This was a report from Australia, and they looked at adult patients who were routinely getting VCUGs within the first 20 months. The reflux rate was 25%, and they observed a higher graft failure rate in the reflux group. However, there was no difference in urinary tract infections between the reflux groups. And this would seem to imply that reflux in and of itself to the graft is harmful. You then have reports more recently that urinary tract infection can increase your risk of graft loss. And this was actually a paper that Walid pointed out from 2019 in Journal of Urology. They observed a much higher risk, even among patients with non-K-cut, a much higher risk of graft loss if they had a urinary tract infection. And the truth is that many of these reports are from single institutions, and there are equally many reports that report the opposite, that there is no increased risk of graft loss. So it's very controversial. However, it is undeniable that UTI is a leading cause of infection after kidney transplant and for hospitalization. And this is, I've consolidated this from national reports from different countries. These are all from national data on hospitalized UTIs after pediatric transplants. And so they are showing you the percent, the frequency that of their cohort that get UTIs, and also the rates. And I'll come back to this because this is what we'll be comparing our data to. So these, as we've said, UTI, reflux, bladder dysfunction, these haven't really been as carefully investigated, as meticulously investigated as it has been for kids with congenital reflux. And so, as you've seen, UTI is so common after kidney transplants, it is natural to ask, is it important to look for reflux in the kidney transplant? This is this graph shows how frequent a VCUG is checked after a transplant here at UW in the past 24 years. And so you can see that up to 2001, there was obviously some variation in practice in how often a VCG was checked. And then since then, it's been pretty routinely checked after following transplant. And what this does is that it really enables us to study what the natural history of reflux is, which again hasn't really been studied very well in transplant literature. So going back to the question, is it important to look for reflux? Is it important to be proactive in order to prevent UTIs? We wanted to look at the UTI rate. You have to look at the UTI rate when you're looking at reflux. We wanted to look at our UTI rate after transplant here, and then also look at the effects of reflux, the use of antibiotic prophylaxis, and obviously you have to look at also their K-cut status and look at the effects of these on the rate of urinary tract infection. So we had to do a couple of things. We had to think about how we were going to define UTI, which is really central to any reflux paper. And the truth is that I wanted to really look at the burden of urinary tract infections. So I decided to look at febrile infections, hospitalized infections, and then total number. And this includes infections treated in clinic and over the phone, which are not always very well captured if you look at large databases. We wanted to look at the use of antibiotic prophylaxis, and this was very time dependent, meaning that patients could be on prophylaxis and then come off of it. And the reflux grade was also time dependent, meaning that if somebody had multiple VCUGs checked for some reason, they could have sometimes a change in their reflux grade. We did look at, obviously we looked and saw who had VCUGs done and who didn't, but this variable, it really is, it correlates very highly with the use of antibiotic prophylaxis. And as you saw, it's also very well tied into a historical cohort who didn't get VCUGs done so often in the past. So we will talk more about that, but these were just some considerations when we wanted to look back at our data. So in all, we had 157 patients who had 170 transplants. So pretty consistent with the literature that we had about 42% of patients with K-cut. And over half of our cohort has about 10 years of follow-up. So we have very long follow-up on these patients. Like that prior article from 1977, we had 77% had VCUGs. And here I've just given you a breakdown of the grade in case you were interested. But you have to realize that grade is dependent on the year after transplant, because again, the reflux status could change if somebody had VCUGs checked multiple times. So I'm happy to report that our UTI rates here are comparable to national reports. So here you can see the differences. Looked at total UTIs, hospitalized UTIs, and febrile UTIs. And the numbers do go down, the frequencies do go down as you look at febrile UTIs. So febrile UTIs is really a very conservative estimate of UTI burden after transplant. But if you just look at hospitalized UTIs and compare it to other national reports, it is comparable. And also our rate of 15 per 100 person years is also very comparable. So just looking at total number of UTIs per year, we looked at, again, prophylaxis status, year after transplant, and VCUG status, and whether they had K-cut or not. And what you can see here is that those who are on prophylaxis had a significantly higher rate of UTIs. And the direction is surprising, right? You wouldn't have expected people being on prophylaxis to actually have a higher rate of urinary tract infections, and we'll talk more about that. Consistent with the literature, every year is associated with an 18% decrease in the risk of UTI. So UTIs are most likely to happen early on after transplant. And then those, again, with VCUGs, just like paralleling what we're seeing here in the prophylaxis outcome, those with VCUGs had a much higher rate of urinary tract infections. And then K-cut, those with congenital anomalies of the urinary tract also had a much higher rate, but not significant. So what we did is that when we put this into a multivariate analysis, actually VOR, the presence of reflux, did not matter. Was not an independent predictor when you adjust for the use of prophylaxis. So again, prophylaxis is a much more distal outcome to look for when you're looking at reflux. So that's what we ended up keeping in our final model. So I'm going to talk more about the relationship that we saw between prophylaxis and whether you had K-cut or not, because K-cut is a subgroup of very high interest in the transplant field. So here I have plotted our data, and here you can see that the dark blue line the blue lines represent the K-cut the group, and then the orange lines represent the non-K-cut group. And if you compare just the darker compared to the lighter ones is reflecting the difference in prophylaxis. And if you compare the dark lines and the light lines to each other, that will tell you the effect of prophylaxis. So when you're on prophylaxis, those with K-cut have a much higher rate. And when you're off prophylaxis, your rate is even higher if you have K-cut. So having K-cut really increases your risk of urinary tract infection, especially if you're off prophylaxis. if you compare the dark lines to the light lines, that's telling you the difference between those on prophylaxis versus those off. If you look amongst those with K-cut, the effective prophylaxis, they had a higher rate. And the same thing with the non-K-cut group. Those on prophylaxis had a much higher rate. That was significant. So it seems that antibiotic prophylaxis is associated with a higher rate, especially amongst the non-K-cut group. I looked at hospitalized UTIs, and I saw pretty much the same pattern. Again, those using prophylaxis have a much higher rate, and you do also see the decrease over time. If you compare, again, just looking at the effect of having K-cut, much higher risk compared to not having K-cut, adjusting for prophylaxis. And similarly, the use of prophylaxis amongst K-cut was associated with a much higher rate, and especially those amongst without K-cut, you're seeing a much higher rate of UTIs if you're using prophylaxis. So why is this happening? I think that the prophylaxis is not effective. You saw very high rates despite being on prophylaxis. However, there's also obviously some selection bias in both the K-cut and non-K-cut groups. So that means that probably if somebody had an infection, they were put on prophylaxis and then they continue to get infections. And that's why you're seeing the effect of the higher rate of UTIs amongst those on prophylaxis. We did see comparable rates to the literature at our institution, which was good. And this is also very consistent with the literature that the effect of K-cut and the early period after transplant are risky periods for UTI after transplant. Interestingly, did not matter whether you had a VUR grade of 4 to 5 versus unknown. That was not an independent predictor of the UTI rate, and therefore routine VCUG may not be very helpful in terms of predicting that. And obviously we need more and prospective studies in order to better understand the effect of prophylaxis, but definitely I don't think our data supports the use of prolonged antibiotic prophylaxis after transplant. Thank you.
Great. Well, thank you, Drs. Farhat and Dr. Su. We're a few minutes over our time, but given this topic, I think we certainly can use a few minutes to field questions from the group for Drs. Farhat and Su. Questions or comments?
Hi, that was such a great talk. Really interesting data, especially from UW itself. Thank you for presenting that. I had two questions. Number one, do we know how long the ureteral tunnels are that the transplant surgeons are doing for our transplants? Because where I was previously, they were doing like less than a 1 centimeter tunnel and told me that their goal was not even to do a non-refluxing reimplant. And then my second question was kind of related to the article we didn't get to discuss at last week's Journal Club, which was Ruthie had put forth a really cool article on the use of probiotics for UTI prevention in patients with normal urinary tracts. Do you think there's any role for trying something like that in our transplant population to see if there is a risk reduction in UTI, since it doesn't seem that, based on our data, that prophylaxis is actually reducing the risk? Thanks.
Thank you, Vinaya. I could address maybe the first question. I had brief conversations with one of the surgeons who already left UW. Unfortunately, he's in Loyola now, and I have attended one of his cases because I was doing the urological component of the transplant. And I don't think there's a good, clear data on the length of the tunnel. I seriously do believe that the transplant surgeon, and I'm hoping that Tony D'Alessandro will watch the recorded video because he's on vacation and he's interested in knowing what our view on this is. they don't care too much about whether there's reflux or not. That's my impression. Sharon Bertosh is also supposed to watch the recorded lecture. So the answer is that I don't think anybody does what we do when we're doing a reimplant. We take the caliper and we measure the length of the tunnel. I don't think they do that. And at least based on my single case watching them do it, I don't think they do that. The second question, I guess, Ruthie would be better to answer. Thank you.
Yeah, thanks, Vinaya, for your questions. I would say that when I was in Seattle, they always did an anti-refluxing anastomosis. They would do a very advancement stitch to really advance the ureter in to really, create that valve mechanism. And then in terms of the use of probiotics, I definitely think it's something to consider. I don't think there would be any harm. One thing I didn't say is that I think it can get a little confusing sometimes because you think that these kids are immunosuppressed and therefore that they're more susceptible to infections. However, they're immunosuppressed in terms of their adaptive immunity and in terms of their T cell function, but their innate immunity should still be intact. And so that's why I think a lot of these UTIs probably are occurring due to abnormal bladder dynamics rather than an immunological reason. But definitely probiotics is interesting idea.
Great. Well, I know there are many subsets of discussions and items of controversy that can be unpackaged from this topic. But in the interest of time, I think we will wrap up. But congratulations to Ruthie and Walid for your work in this area, and certainly look forward to seeing how you progress with it. For Mr. O'Kelly, who's joining us, we are going to switch over to another WebEx Zoom platform for our internal meeting, and then you'll rejoin the residents at 8:30 our time. So thank you in advance for your time, and great to have you here as well. Okay, thanks everyone. We'll see you shortly on the next WebEx.